Hello, I'm Stephen Denton, and I'm here to tell you about my research project titled Early Outcomes in Targeted Muscle Reinnervation for Traumatic Amputations. This project was supported by the Department of Orthopedic Surgery at the Medical College of Wisconsin. Over 2 million amputees reside in the United States alone, with that number expected to double by 2050. The majority of these amputees suffer from a combination of residual limb pain, or RLP, coming from the remaining limb stump, and often caused by neuromas, and phantom limb pain, or PLP, coming from the amputated limb no longer present, the mechanism of which is poorly understood. These pain symptoms reduce the quality of life for patients by increasing pain medication use, namely opioids, and reducing prosthetic use and subsequently ambulation. A leading traditional treatment for RLP involves surgically excising painful neuromas and burying the nerve fascicles in nearby healthy tissue to protect the nerve by providing padding and a protective environment. However, over time, the nerve is destined to regrow and will form a new neuroma, rendering the treatment largely ineffective. In addition, this treatment does little to address the PLP symptoms patients experience. An evolving treatment, targeted muscle reinnervation, involves surgically excising neuromas from severed nerves and subsequently coapting those nerves to the divided motor nerves of a nearby skeletal muscle. This results in many of the severed nerve fascicles growing down the motor nerve and connecting with the muscle's motor end planes and sensory receptors. Although initially developed for use in myoelectric prosthetics, previous studies have shown TMR to be effective at preventing neuroma recurrence and subsequently reducing RLP and PLP. While initial outcome data is encouraging, existing studies are relatively low power and lack long-term follow-up. Further studies are needed to assess outcomes of targeted muscle reinnervation after amputation. The specific aims of the study were to evaluate the mid to long-term effectiveness of TMR after traumatic amputation. Our objective was to contribute our patient population to the existing literature and determine if our results were comparable. The following variables were examined in patients beyond 1 year post-operation: RLP, PLP, and prosthetic use. We hypothesized that TMR after traumatic amputations would result in higher prosthetic use and lower standardized pain scores relative to historical norms in adult upper and lower limb amputees who are beyond 1 year post-treatment. The patient population we examined included 23 traumatic amputees, 19 lower limb, and 4 upper limbs. All patients were adults over 18 years old, and exclusion criteria disqualified patients with less than 1 year of follow-up data. A population control was obtained by comparing data from our results to the TMR and non-TMR patient populations examined by Demanian et al. In 2019. Retrospective chart analysis was performed using EPIC. Data gathered included patient demographics, dates of procedures, and comments on pain and function during follow-up visits beyond 1 year. Of these patients, 17 were administered surveys via telephone, with the remaining 6 unable to be contacted. Pain was evaluated in all patients using a validated pain scale and administering PROMIS Pain Interference Short Form 8A. Functional status was investigated using the following standardized surveys: NeuroQOL Item Bank version 1 Lower Extremity Function Mobility, and PROMIS Item Bank version 1 Physical Function with Mobility Aid Short Form for lower extremity patients. The Orthotics Prosthetics User Survey Upper Extremity Functional Status Questionnaire was used for upper extremity patients. To date, chart reviews have been completed for all 23 patients, and 17 patients have been administered surveys. Statistical analysis of the results is currently underway. Our next steps include performing standard t-tests comparing our patients' pain and function survey data versus 1, the TMR and non-TMR patient population survey data in Demanian et al. 2019, and 2, the U.S. general population, the results of which are contained in the standardized PROMIS, OPUS, and NeuroQOL surveys we administered. Our next steps also include automating the administration of surveys via MyChart to all future TMR patients, and we anticipate the study being continued for the next 3 years to increase our sample size. At the completion of this project, we will determine whether or not our patient population saw mid to long-term improvements in pain and function resulting from their TMR surgery. We will also see if these outcomes align with historical norms drawn from previous studies. Looking forward, our pain and function outcomes may provide evidence supporting the use of TMR surgery for preventing RLP and PLP in traumatic amputations. Future studies may include extended monitoring of patients beyond 1 year to assess long-term outcomes, as well as increased sample sizes to increase statistical power. I would like to thank my mentor, Dr. Anthony LoGiudice, for his immense support throughout this project. I would also like to thank Dr. Connor McBride for his wonderful assistance and support as well. Thank you for listening to my presentation.